Welcome to Better Health Guy Blogcasts, empowering your better health. And now, here's Scott, your Better Health Guy. The content of this show is for informational purposes only and is not intended to diagnose, treat, or cure any illness or medical condition. Nothing in today's discussion is meant to serve as medical advice or as information to facilitate self-treatment. As always, please discuss any potential health-related decisions with your own personal medical authority.
Hello, everybody, and welcome to episode number 49 of the Better Health Guy blogcast series. Today's guest is Dr. Mary Ackerley, and the topic of the show is Brain on Fire. Dr. Mary Beth Ackerley is a classically trained, board-certified psychiatrist. She graduated summa cum laude from Harvard University, studied at National Institute of Mental Health, and finished her residency in psychiatry at Johns Hopkins. Currently, she is an integrative holistic physician who specializes in natural treatments. Patients commonly come to her with conditions of anxiety, depression, and chronic fatigue. Her treatment protocol for biotoxin illness combines a variety of methods, including conventional and integrative medicine. Her expertise includes differential diagnosis from brain MRI analysis in conjunction with Neuro Quant software. She has also uncovered a statistically significant relationship between methyl-resistant nasal pathogens in relation to hidden dental infections known as cavitations. This discovery is linked to neuro-inflammation with psychiatric implications and has led to greater improvement in diagnosis and treatment. Currently, she is researching the effects from biotoxin illness on oxygen absorption and metabolism. The malabsorption of oxygen leads to severe physical debilitation and exhaustion with an inability to accomplish simple daily tasks. Her internet article entitled Brain on Fire is widely acknowledged as a pre-eminent summation encapsulating the psychiatric implications from acquiring biotoxin illness. Her private practice, called My Passion for Health, is located in Tucson, Arizona. Often she's contacted from around the world consulting through Skype about complex cases. And now my interview with Dr. Mary Ackerley. The topic of mold illness is such an important one to be discussed. I personally was impacted by mold illness twice, and I think that many people struggling with health issues today are unaware of the role that water damage building plays in their condition. I am honored to have one of the experts in this area with us today. Welcome, Dr. Ackerley.
Hi.
Thanks for being here. I appreciate it.
Yeah.
So tell us a little bit about what took you from the world of psychiatry into treating people with chronic illnesses such as mold illness, Lyme disease, and chronic inflammatory response syndrome. Did you have some personal experience with any of those with your own health?
No, I haven't, which I consider myself more lucky than anything else. And I also thought, it's really doesn't speak well of medicine that you have to even ask me the question, how did you get interested if you didn't have the illness yourself? Because it speaks to the fact that medicine is pretty closed-minded about anything that wasn't learned in medical school. I did have my own experience with illness with Hashimoto's, which was similar in that I was used to enjoying pretty good health. And I found in the mid-90s, I was getting sort of sluggish. My thyroid was off and I started thyroid and I thought, no big deal. Thyroid is good for mood and energy. And I just did, Synthroid. And over the years, I was getting more tired and gaining weight. And I gained, I think up to 80 pounds. And I'd go see the thyroid specialist. We had moved from Florida to Arizona. And I learned what you call the silent eye roll treatment was happening. And that the silent eye roll is when doctors aren't going to tell you directly to your face, but you can feel they don't believe a word of what you're saying, and that they know if you just exercise more and ate less, it would be fine. It has nothing to do with their thyroid. And then I got desperate enough, and I do say that, to go see a naturopath, because being from the East Coast, I had not even really known what a naturopath was, which again speaks pretty poorly of the kind of medical education I had. And she put me on natural thyroid, or actually she put me on compounded with T3. And I thought, yeah, that's right. I've done research on T3. I know it's essential for mood, but my Synthroid was enough. She said it wasn't. Long story is basically the weight just started rolling off. And it was, I started feeling better, looked better. And at the same time, she also did antibody testing and said, oh, you have some elevated numbers here, but don't worry about it. And I thought, okay, again, I believe what the doctor told me. The weight was rolling off. I was feeling good, but that was about the time Hashimoto's began to get a little bit more known in the popular press or on the internet. And I started reading and I said, oh, this means I have a leaky gut. Oh, this doesn't mean I just had a virus once and it's over. And yes, and so my journey has been of, yes, the disdain. I've certainly felt the disdain of doctors looking at their treatments, not working, and knowing it's your fault, not theirs. The having then an illness that really isn't known. And still to this day, I just switched my primary care again, because the last one I had looked at me and said, no, you don't need to measure your antibodies. It's just a one-time event. And you don't need to be on natural thyroid either. And it was like, and your TSH is too low. And it was like, oh my God, it's 10 years later. And actually it's getting worse. It's becoming harder for all of us as doctors to keep doing what we know is right, because we get, letters all the time from Medicare saying, essentially, doctor, you're killing your patient with natural thyroid.
Wow.
So that is, my own struggle, which I think removes some arrogance, knowing that my body's not perfect and that the patient is usually right. And it's the doctor who usually doesn't have adequate knowledge to treat them. So that was about the time I started doing what I would call integrative psychiatry. It was pretty obvious back then. Antidepressants didn't work as well as everyone thought they would. And the research was coming out that the drug companies had hidden all the research that was not favorable to them. So while I was learning about gluten, dairy, integrative, leaky gut, adrenal fatigue, supporting the thyroids and stuff, it was a natural time to switch more of my practice over. And this is leading into how I got into CIRS. Is I began seeing a number of people who were getting treated by another mold doctor who still is in Benson, pretty well known. I think you had one of his patients on a few weeks ago, and they would come to see me because they had hormone issues, which, yes, are important in CIRS, and mood issues, and they wanted more treatment than the binders. And I'd look at them, and very honestly, again, my training was, I didn't learn in medical school, mold only gives asthma or allergies. This is classic psychosomatic illness. They're, thinking they're reacting to something. But at least I had learned to not even give a silent eye roll. I was nice, I was compassionate, and they kept coming. And at some point, within a year or so, I began looking at the lab saying, I've never heard of any of this, which is what most people will hear when they show it to their doctor. But I actually got curious, started doing it. And then eventually I had a couple of patients where I started to treat them, and I got them better. One with something that looked like dementia, another with diarrhea that just wouldn't stop. And she had been diagnosed with MS, plus anxiety, depression. And I got a lot of that better, except the diarrhea. And then I said, you might have mold. And she had mold in her home, pretty much everywhere from a bad renovation. And I began to learn that, yeah, mold is real. It makes people sick. You can get them better. And I got very interested in treating it.
So how much of your practice now has shifted from purely psychiatric presentations to more full body, system-wide health challenges like CIRS?
That's a good question, because I'm not sure there's ever a purely psychiatric presentation. There are people who don't ask the right questions and don't do a review of symptoms. And if they did, they find that there's very rarely something that's purely psychiatric. There are almost always physical symptoms involved. when people are younger, it may seem more purely psychiatric. As they get older, there are always physical complaints. And so I think I've become more and more aware of how many people with depression, anxiety, bipolar actually have associated systemic illnesses from inflammation and from infection. So I think it may have always been there. I'm just far more aware.
So then let's talk a little bit about the topic of inflammation in general, and then we can move into some of the topics around CIRS and water damage building illness. So you've been associated with the term brain on fire, and I'm wondering if you can just tell us what you mean by brain on fire and what are some of the things that contribute to a brain on fire?
Brain on fire is a way of saying neuroinflammation. And neuroinflammation is a very hot topic in neurology, psychiatry, endocrinology, perhaps even too, because most of the neurodegenerative diseases, the stuff we all fear the most, Alzheimer's, ALS, Parkinson's, are primarily neurodegenerative, neuroinflammatory illnesses. And the research in psychiatry is also extremely strong that every psychiatric illness I've ever looked at has research supporting neuroinflammation as the major cause or one of the major causes. It's certainly there. And if we talk about autism too, neuroinflammation is also very clearly present. So the question is what percentage, what actually was the question?
Well, the earlier question was how much of your practice has really shifted to these more systemic illnesses, but then just kind of setting the stage for us about what brain on fire is, which I think you did.
It's more technically activated microglia. What activates them, usually the fire, is cytokines, and cytokines are the inflammatory components of the immune system, essentially the hormones or the messengers white blood cells of the immune system release to communicate. And in that communication, a lot of collateral damage occurs. They're also released to kill things broadly and non-specifically.
So let's talk then a little bit about depression. We talked about antidepressant medications briefly. I've been reading more and more how inflammation can be an underlying contributor to depression and how even anti-inflammatory interventions can be helpful for those people struggling with depression. And so I'm interested in your thoughts about the role of inflammation in psychiatric conditions or in symptoms such as depression.
Let me go out from another tact. In 2008, it started to become clear antidepressants. The research was not forthcoming about some of the problems. By 2010, you're having books written saying that basically antidepressants aren't better than placebos, and there's an enormous outcry in the psychiatric community, but I see them work all the time, and people didn't understand placebos work. All we know is that people get better, and placebos make people better. So it's gotten to the point now where there's enough research done from the opposite point of view that maybe they don't work, that a paper recently came out that said at this point, antidepressants or SSRIs carry more risks than benefits in giving them if you just do really good meta-analysis of all the data. So the idea is that antidepressants, SSRIs in particular, handed out like candy. 1/4 of all women from the ages of 40 to 60 are on antidepressants. It's about, I think, 12% of the population now is on antidepressants. And I always point out, if they really worked, the leading cause of disability now or by 2030, depending on what survey you look at, is depression. So obviously, antidepressants don't work. We've made advances on cardiovascular diseases, cancers, the things people have feared. Those mortality rates are going down, and depression is the thing that doesn't budge worldwide. So that's my way of saying is inflammation clearly is very linked to depression or anxiety or whatever flavor psychiatric illness a person may have. It's the brain is showing the components of the immune system are activated, enlarged. There are cytokines, there are problems then with blood flow and communication, and downstream from that, neurotransmitter problems. It's not the major problem.
So it's not just depression that inflammation can play a role in. People that are also struggling with anxiety, it sounds like inflammation can play a role there as well. We know that in chronic inflammatory response syndrome, that a lot of the symptoms that people experience from water damage building exposure or from Lyme or whatever the trigger is are driven by this inflammatory cascade. And so could we say that inflammation is really the core of many of the complex chronic conditions and issues that people are dealing with today?
I think so. I absolutely think so. And I think the research in psychiatry just gets stronger and stronger. There's some research that's come out now that's not only indirect with inflammation, but actually can show with PET scans inflammation linked to different circuitry in the brain, one in OCD, the other in suicidal ideation. You can measure a protein that is linked to neuroinflammation, and it really lights up the circuitry in OCD, and then it's also lighting up in people who are thinking about suicide too. So worse than if they just had depression. So those are more direct correlations that, yeah, the brain and the circuits in the brain are inflamed in these things we're calling anxiety, OCD, depression.
So in people that come to work with you that are dealing with significant anxiety or significant depression, what are some of the interventions that you find helpful in helping them to deal with those symptoms? And oftentimes I hear people talking about neurotransmitter testing and trying to balance neurotransmitters and all these kind of finer adjustments. Is that a place that often leads to higher ground, or is it better to kind of step back and look at the inflammation and removing things that might be contributing to the inflammation?
I personally think it's a downstream event. I don't measure urinary neurotransmitters for a couple of reasons. One, psychiatry's been doing that since the 50s. I did that when I did research at NIMH. I was, the one collecting the 24-hour urines and getting them ready and aliquoting. And there are urines buried all around the beltway of patients forever, because the answer for many years in psychiatry was we were going to understand everything as neurotransmitters. And I try and point out to people, if it really worked, psychiatry would be doing it. If there was really a test you could send off like this that was this inexpensive, that would tell you, oh, it's a serotonin deficiency, they'd be doing it. That research has not panned out, and I think it's officially been pretty well buried. Yes, there are neurotransmitters in the brain. They do things. It's not even clear at all if the urine is reflective of the brain or of the kidneys. It may reflect more what a person just ate. If you try and treat just with one neurotransmitter, you put the other neurotransmitter systems out of balance too. So just adding serotonin to a system without trying to give something to support dopamine is going to lead to dopamine imbalances, etc. And often if you talk to a patient, if you actually spend time with a patient, you can figure out, yeah, there's depression, there's some severe mood, there's anxiety, there's real focus issues, which may give you some ideas that some supplements that lean more toward one or the other may help. But I've done neurotransmitter testing with supposedly a more perfected method. It never really worked for me, but I do use amino acid supplements for people in a balanced way that does seem to help. And I know things help when people keep using them for years and they feel it helps their mood.
So when we look at some of these pro-inflammatory cytokines like IL-1, IL-6, TNF-alpha, maybe even MMP9 and TGF-beta-1, what do these actually do in the body, and what is it that they do that makes us feel symptoms of the condition or makes us feel sickness syndrome, if you will, or symptoms of sickness?
Okay, that's a pretty complicated topic to go over all of them, but MMP9 does literally contribute to the permeability of the blood-brain barrier. It liquefies from the inside out, so it will go from the bloodstream out through the tissue, out through the vessels into the tissues, causing inflammation and pain. So, and it does that to the blood-brain barrier. TGF beta, it's probably the most widely measured and actually one of the most useful for me. Cytokines does a lot of things for cell growth and cell death, and it is contribute to things like thickening of the lungs, perhaps skin tags and polyps. Those are things people don't usually know. It probably also contributes to the permeability of the blood-brain barrier, and it certainly is associated with Alzheimer's in the brain or in the cerebral spinal fluid, so as well as having effects in the rest of the body. Interleukin 6, which I do measure, I think you asked which ones, I will measure that in patients who may have strong family histories or strongly depressed suicidal histories. And I do have patients where it's very elevated. Getting that down, you usually need to do a little bit more than CIRS, but it is just very strongly associated, again, with depression and inflammation. Also cardiac effects, too, in the body. So that's a sum. I mean, cytokines have a lot of different roles in the body. Some actually will try and quiet the others. TGF beta has a dual role in promoting autoimmunity and balancing autoimmunity in Tregs. So it's really complicated. It's very hard for anyone to take one thing in a body, measure it in isolation from the others.
But it sounds like it is these cytokines that lead to inflammation that makes us feel many of the symptoms that we have when we have a chronic complex illness.
It's all the symptoms that feel flu-like. When you say flu-like malaise, those are cytokines. And at the worst case, you're having cytokine storms or Herxheimer reactions that are severe. It's that aching flu-like feeling that...
So is it possible that what many people perceive as someone maybe having a mental illness, that they may actually be dealing with the end result of infections and toxicity and chronic inflammation, and that their mental illness may actually have a very physical cause, and it's just being overlooked or ignored by whatever practitioner they're working with?
Absolutely. I wish if I had a grant money, it would be to go into a psychiatric hospital and just measure cytokines. The mold ones do Lyme DNA testing of every patient there. I think that we'd be looking somewhere like between 50 to 80% of patients there, especially the ones who are hospitalized, would be having inflammation with some sort of cause like mold or Lyme or perhaps other bacteria behind it. And that probably would be low. So that is my belief, and where I go with most people is that when we're talking anxiety, depression, hallucinations, that I'm looking for inflammation. There's certainly psychological. To me, that's very different than the brain-based psychiatric symptoms we're talking about.
So in getting a sense then for a patient's level of inflammation, do you primarily look at the shoemaker markers like C4A, TGF beta 1, MMP9, or are there additional things that you find helpful in kind of gauging how inflamed someone might be?
I do use those a fair amount, and depending on a person's insurance and where they live, over time, I think they can tell a very accurate story of where people are with inflammation. It's always nice to see them going down. And when they go back up again, it helps figure out, are you having exposure? So people will say, does this mean it's all I have? And I will always say, no, I don't think so. But you have a pattern here of a number of things that certainly mold is there. And we need to make sure that that's not part of it too. Mold is just a very, very common problem for a lot of people. So VEGF is also really important too. And VEGF is a little different. It's a growth factor. It doesn't make inflammation so much, but it's very involved in the perfusion, capillary perfusion in the extremities. In the brain, though, it's reflective of neurogenesis and making new synapses. Low levels are associated with suicide. And I've begun to understand more of a number of psychiatric symptoms occurring, not just with inflammation, but not enough delivery, essentially, of oxygen and nutrients to the brain, which is patchy, which is part of the malaise of chronic fatigue. It's that part where people have gone over their anaerobic thresholds or anaerobic metabolism, and the brain is not getting enough supply of glucose and oxygen to run properly. So that's not quite inflammation, but it certainly is something I see contributing to depression, anxiety, and even hallucinations in a couple of people.
So talk to us a little bit about quinolinic acid and how that fits in with chronic illness. How does it tie in with inflammation? What are maybe some of the illnesses where we think about quinolinic acid, and then what can we do to reduce it?
It's an excitotoxin, essentially. It's made during in inflammatory states from the degradation of tryptophan. So instead of going on to make 5-HTP and so forth, it's actually degraded into a substance that causes the death of neurons and too much glutamate to be made. Has its twin kynurenic acid, which is probably even more severe. So both of them can be measured and clearly do bad things in the brain, are associated again with depression and suicide. And I don't routinely measure them, but I will look at people getting testing from various proprietary labs. I had someone come in a couple of weeks ago who was sent to me because her patients, her labs might have indicated mold, and I wasn't sure about that, but I looked at the ratio of the quinolinic acid, I think, to 5-HIA, which is the metabolized serotonin. It was the highest I've ever seen, and I said, there's really a biological basis here underlying the fact she'd nearly been hospitalized the week before for suicide and depression. And I said, wow, it's pretty amazing here, but I think this supports the fact that, where you're living is not doing you any good.
So when someone comes to you with either Lyme disease or chronic fatigue syndrome or fibromyalgia, or maybe they think they have chronic inflammatory response syndrome, what are some of the key contributors that you see in all of these conditions? What are the big players in your mind that need to be explored in order to move someone towards wellness?
I do have an order and a preference, and I think certainly the doctors I work with around the country have similar orders that we see increasingly, what I call the chronic complex patient who is seeing multiple doctors and beginning to realize they have a number of issues. Is mold, to me, is the most important issue because of the profound dysregulation it does of the immune system and of the hormonal system. So it's creating widespread chaos in a body. And I think very few people are successful in dealing with anything else until the mold starts to be recognized and treated. And what are the other else? All of us walk around as a petri dish. I mean, we do. We all have viruses and bacteria in us. That's how our immune system develops. And I'm from the East Coast. I grew up on Long Island. I found out much later in life that the place where I used to associate with camping, Girl Scouts in church, we'd camp out on Shelter Island. What is Shelter Island next to? Plum Island, which I found much later in conspiracy theory is the site of Lyme. But I thought, wow, I spent a lot of time on Shelter Island, Long Island. I was taught to burn ticks off, don't remember tick bites, but nobody was looking, nobody was thinking. So I think that a number of people, especially from places where it's more endemic, are probably walking around with spirochetes and co-infections because nobody cared about tick bites for many years. In fact, I would say maybe not till 2000 did people take it really seriously. And so not everybody is sick with Lyme. What happens is, I think in many cases, the dysregulation comes from mold, which is very common and becoming more common, and things that have been safely, tucked away by the immune system are all let loose again. They're never really killed. They're just held in check. And now the guards are all, I say, drunk. They're asleep on the job, and the Lyme and co-infections come out, as do the viruses, because 90% of us have Epstein-Barr by the time we're 60, and I think 50% by the age of 5. Your grandmother gives it to you, not your, partner as a teenager. So these viruses and things we haven't even discovered, being, healthy means your body is handling it. And mold just seems to be a primary player. So when I see mold, people who are coming to me is with fibromyalgia, chronic fatigue, I'm thinking mold and Lyme and co-infections as the major sources of what's going on. And I think the cases where that hasn't been true, I'm trying to remember if I've really seen any. Okay.
Wow.
I'll be working on mold and getting labs, but thinking about Lyme and co-infections all the time, of starting with at least LabCorp's Lyme test, which may show some stuff, and getting an environmental history from people, which is, where did you grow up? Arizona doesn't have much, but if you camped out, we definitely do have it. So I don't see as much of those, my colleagues who work in New York or Massachusetts. But people move all the time. And so a lot of people lived in the Midwest and always were playing with ticks or dogs, or grew up on the East Coast and in California too, where Lyme is prevalent. And so it's a possibility for a lot of people. I'll ask about mono and viruses, and we'll do testing depending on the severity of fatigue at the first visit, trying to get an idea, what's the viral load, what's the, what am I looking at here with Lyme co-infections, and how well can I prove that mold is in existence here for this person. I assume everybody has parasites, and again, that might be more of my integrative training, is we're taught, every other country in the world really, as you go across the border to Mexico, parasitic medicines are just sold in the drugstore. You don't need licenses. Everyone assumes parasites are normal. So really 30 miles from the border, why are the parasites not moving, here? It's parasites are very common. I'm always surprised people are still very grossed, and they've been handling dogs and horses and deworming them for most of their life. So I think parasites are very under-recognized, and I usually will start some gut treatments that may start to help, because I still have yet not found a really good parasite testing. I've never found one that I just know, oh, absolutely, if you don't have parasites on this, you don't have parasites. So parasites to me are part of the issue. Heavy metals are very, very common. I just taught a seminar with Joe Pizzarno on, environmental toxins, and I learned so much. I was more scared than probably the people I was scaring about mold, about how incredibly toxic our planet is in the air, the water, and the soil. And all of us are walking around with all of that somehow we're healthy. Most of us are healthy and held in check. And there are trigger events, which I say, mold is like Mrs. O'Leary's cow. It kicks over the bucket. It starts the fire. And now you can't pretend that you don't have all these co-infection viruses, heavy metals, and stuff going on. And you're really better off knowing about it than before you get Alzheimer's, in my opinion.
I absolutely agree. So when you're dealing with parasites, do you find that the natural options, herbal options and things are often enough, or do you tend to approach it with some of the pharmaceutical antiparasitics?
For the most part, I'll start with the, normal things people have used, the Hulda Clark type remedies. I don't think the zapper works, by the way, and someone's going to ask me that. But,
yeah.
And I think it may have worked 20 years ago. It's been around a long time. People are like, have you heard of the zapper? It's like, yeah, I'm that old. Normal black walnut, wormwood, sorts of things like that you can buy over the counter. And again, it would be for people who are having, constipation issues or diarrhea issues that aren't going away. It's certainly something to be considered. And I suggest to people once a year, just the way you take your horses, which they do twice a year here, or dogs, you should think about doing some sort of cleansing for the body.
Yeah, that makes a lot of sense.
Yeah.
So while we're talking about the chronic infections, what role does autoimmunity play in inflammation that may result from chronic infections? Do you sometimes have to step back and do something specific to downregulate the hyperactive aspect of the immune response in order to also control inflammation?
I look for autoimmunity on the first visit. So I do think there has to be some genetic component which sets off autoimmunity too, besides, because not everybody exposed to mold and Lyme and parasites also has autoimmunity too, but I will look for Hashimoto's for everybody. I'll look at ANAs or rheumatoid factors in people having joint pain. I'll ask, is your mom lupus? Is there a history of autoimmunity in it? The first things I do are probably pretty much the same as binders, getting out of exposure and seeing how people do. In terms of specific for autoimmunity, my understanding is if you have Hashimoto's, you have leaky gut. If you have autoimmunity, it's very hard to explain how you would have these antibodies without having some problems with gluten also. And I do try very hard, usually when people are sick, to get them on a paleo diet, because I think you asked about that, is an autoimmune paleo diet. If we already know that there's Hashimoto's or lupus or some sort of autoimmune problem.
Very good. So let's talk then a little bit about chronic inflammatory response syndrome, get into some topics around MARCONS, VIP, Neuro Quant, things of that nature. So the first thing I was interested in was your thoughts on the ERMI, which for those listening is the Environmental Relative Moldiness Index from Mycometrics. I'm wondering if that's something that you do with most of your patients. Do you find it consistently helpful? Do you occasionally find that it actually looks pretty good and later find that there was actually a significant mold issue? And then do you get to a point where you send someone out that's an indoor environmental professional to do some deeper looking for the potential of mold?
Okay. First of all, at this point, most of the people I see coming are pretty clear that mold is an issue, so they're not too opposed to starting to do some testing. When I started, because I really started doing this in 2010, and I didn't know about ERMI or hurts me, it took a lot more convincing to suggest mold, and I was using plates, air plates and stuff, because that's all I knew about. And then people would call in environmental professionals. And really, some of my first cases here, I became aware of somebody very talented in Tucson who I introduced to the shoemaker list and who's gotten to be very knowledgeable, Mike Schrantz, who is from Tucson too, and who does travel. So I've been very lucky to work with somebody, an IEP, who believed in the mold, that mold caused health issues, which a lot of IEPs don't. But going back to, then I learned about the hurts me and the ERMI and realized, this is an inexpensive way to at least start to know if people have problems. And I do ask people to do those the minute I start to think there are issues. Sometimes people wait to see, well, you're going to prove there are issues with my labs, because they really don't want to know about their home, because if you own, this is not, there's a lot of monetary costs involved. And I usually recommend the hurts me simply because of costs, and I'm conscious of costs. This is a marathon, this kind of illness. It's not a sprint. It's not like we spend all the money and we fix it and you never think about it again. So I will often start with the hurts me. If people are well into knowing that mold is an illness and now they thought they were better and now they're ill again, then I may talk about an ERMI and seeing if there are more allergenic molds involved, because we probably will talk a little bit about mast cells here too, because that's so intertwined with CIRS and psychiatric issues too. So anyway, that goes to say is the hurts me would be the basic, and I teach people, don't do the vacuum tests that always will show just about it's okay, and plenty of those have turned out to be false. Over the years, as people were given false senses of security, they vacuumed 2 rooms, which is, I guess, what is the official instructions for it. The rugs were clean. There's no issue. They're getting sicker. They have cytokine elevation. They're not getting better. And then I'll find, oh, you did the hurts me, not doing the dust test in every room. So it's the dust in every room that's 30 days old that's going to be the most accurate. So I ask people to collect dust from the top where they don't vacuum. And the sicker people are, the less likely they are to be able to reach their arms above their shoulders. They're not dusting the top of grandma's cabinet. Those are the best places to collect dust. It's old. and you want to do it from every room. And Michael say, well, that's going to oversample. Yeah, we're oversampling. We're just trying with $150 to get a shot. Are there bad molds in this home? And so those are my instructions usually, is get the Swiffer cloth, collect dust from places you haven't been dusting or vacuuming. The top of door jambs, the top of windowsills are all good places to do it. Do it in the bathrooms, do it in the laundry rooms. I'm not sure the instructions are to avoid that. And it's like, those are the most common places of mold. We're just trying to get an idea. Do you need to call in a professional? So when you call in a professional, you'll get better testing and it will be more money. So those are reasons why Hertzme's can be inaccurate. Using the vacuum, not using old dust. People go in and the place has just been cleaned professionally. They're trying to look at an apartment and get something, and it has been cleaned professionally, and they don't collect the bad dust. You want to give it 30 days to collect. But I'd say, you asked me what percentage, maybe 10 to 15%, even when done correctly, will not catch mold behind the walls. For the most part, can be argued. In the ceilings in Tucson, because the question you haven't asked me, Scott, is why are there so many of you in Tucson? You're Tucson doing mold. You're where everybody's escaping to get away from mold in obviously moldy places, is because we have flat roofs that leak, and there's a delusion in Arizona that rain that comes in during the monsoons is exempt from the natural laws of nature. It doesn't grow mold. It's not a problem. So we have enormous issues in all the older homes where mold has gotten in through the roof, through the walls, and it can be hard to detect that.
And I've actually heard that because it is so dry there, that then when there is a rain that comes or whatnot, that it just kind of gets sucked into the structures really readily, that it can get brought into the houses that way as well.
We do seem to have a fair amount of mold in the outdoors. I mean, Mike, I've seen samples and it's frightening. We do have stachy high numbers at times outdoors, or aspergillosis. And the other thing I've been told is that the mold that survives in the desert is stronger. It's more vicious, and there may be some truth in that or not. But I think the biggest problem we have is incredible ignorance of mold in Arizona. No, I moved here, and it's the number of people I've seen move here not knowing we have an issue, who didn't do Hertzme's, who end up in worse situations, is unfortunately very high.
So when someone needs an environmental professional to come in, how do they find someone that understands CIRS well enough to do a meaningful evaluation? What I commonly see is they get an IEP, they come in, they did some air sampling, they left, they said everything looks good, but they didn't understand that mold can even create illness, let alone anything relative to kind of the whole CIRS arena. Is there some list or resource? How do you find those for people that are out of state?
Well, I hate to have to share Mike any more than I already have to share him with the world, but he and Larry Schwartz, I believe, do consults over the phone with people to help guide them what they need to find locally. And I know Mike and Larry also will travel. Those are the two professionals I'm most familiar with in terms of them knowing that this is a real illness and how to evaluate homes for very sick people.
Perfect.
So they are a really good resource, and we hope to have more, obviously, as time grows. But it takes a fair amount of training, and there's a lot of disbelief in that industry. Some of them, I think, have inhaled more mold spores than they should have for their brains, and they will tell people it doesn't really make you sick. We're wearing the hazmat suits for effect. People have been told some pretty insane things, that their homes are safe when they're not safe at all.
So you were actually the first person that I ever heard talking about MARCONs being found in dental cavitations. I think that was at the conference in Irvine in 2016. And so I had a couple questions around that. Number one, do we know if root canals potentially also are a source of MARCONs?
Yes.
And then I'm wondering, what are some of the more recent findings in that realm? If someone has a dental cavitation where MARCONs is identified, does it seem that ozone is enough to address it, or do they actually need to go have a cavitation procedure done potentially?
Yes, root canals that are infected have been cultured and absolutely have shown mark-ons. Teeth that are, need to be extracted, we've, cultured those show mark-ons, and cavitations have shown mark-ons too. And so it's very clear it exists in the jawbone and in teeth. So treatment, again, I'm lucky in Tucson, or maybe we're just lucky we have enough patients, there's enough demand, is that the dentist I work with particularly is trained in the use of ozone as well as doing cavitation. She's done a lot of the culturing for the work I've done with it. And she's been able to show that using ozone treatment has been sufficient in shrinking these cavitations to the point where they can't be seen. And it is much less expensive than having the surgery. And I think, as you know, with surgery, the cavitations can reoccur. With the ozone treatment, presumably they can reoccur too. And people are getting, checks or scans, I think, every couple of years after they've shown they've cleared. Especially, I will send people back if we're having some enormous problems again and we don't know what's going on. But so far, ozone treatment for cavitation seems to be efficacious, if painful, and there's no doubt that it's painful, but helpful, very helpful. So I would say ozone is useful and is probably worth trying, simply because it's going to cost so much less than doing surgeries, and there's no guarantee with surgeries that it's a permanent solution.
Right. Yeah, that makes a lot of sense. So in terms of treating mark-ons, do you think now that the colloidal silver EDTA compound is available, do you think that people will move away from bag spray, or is bag spray still something that still has a place? And then do you use any natural options for dealing with mark-ons, like silver sprays or herbal sprays? What have you found that's really effective in treating mark-ons, if anything?
My discovery, I guess, of mark-ons came about because one of my patients had trigeminal neuralgia, which the other name for it is suicide illness. It's been known, for many years as one of the most painful conditions you can have. And it was his culture that was positive that started the search for other ways to get rid of mark-ons. When I started doing this, it was fairly routine to give bag and to clear people. It wasn't something I really thought much about. People with 6 or 7 resistance would still clear in one pass with bag. It has become increasingly difficult over the years to clear this, and we're showing increasing resistance in people for a variety of reasons, of which what is the cause isn't clear. Is it bag? Is it antifungals? Is it a combination? Is it an infection which has now become so community spread that it's just easier to acquire? I don't know. My basis in training really, or my own basis or bias, is much more natural and integrative than pure allopathic. So I really understand unintended consequences from things that are beneficial, seem beneficial, but 30 years later show enormous problems, of which antibiotics is the one everybody understands. Antidepressants are now on that list too. So short-term solutions often create longer-term problems that take a very long time to show scientifically, which is a way of saying that, yes, bag is being used less because it seems less efficacious, and it remains to be seen now, is EDTA silver going to be creating problems also? How old are bacteria? 4 million years old. They're older than us. They're smart. They have survived. There's an NPR article a couple of people have told me about. I need to check. I can't believe it. They've dug up, I think, was it mummies or some sort of ancient graveyards, and they found bacteria-resistant species and antibiotic-resistant species. How could that be? We didn't have antibiotics. So that has really made me wonder about what exactly we're looking at, what is going on with community-based infection, and I think that's happened in Lyme and co-infections too, is that you can't just, antibiotics are great, people get better and go on until it happens again and again, and you realize now you've tripled the risk for diabetes, et cetera, with antibiotics. And so, I think different ways of looking at it are really necessary. I'm looking at probiotics, which right now involves kimchi or growing it yourself, and there are instructions on the internet, and I'm looking at that. I'm looking at some of the herbals too, biocidin, which has been used, coptis, which is said to work, iodine, which does work for MRSA, betadine, which is used in hospitals. There's suggestions, but I think the thing may be is at some point we have to realize Marcons does seem to be bad. It's one of the few things I'd have to say that with treatment, I often get people saying my anxiety is much better. Oh. My depression is better. My thinking is better. It seems pretty clear for a number of people, whatever is being secreted by these bacteria does affect the brain. The nose is very close to the brain. We know the brain-blood barrier is permeable in many of these patients, and it does seem to affect the brain function.
I did try that Kimchi Experiment. I put it in a nasal spray bottle, and the kimchi that I had also happened to have a little bit of jalapeno in it, and it was very uncomfortable. But I think the kimchi alone can also be a little uncomfortable. It can definitely burn.
Okay, that's why I've deferred from doing that, because I didn't find the kimchi yet, and I have, I think, a sausage maker's culture to grow, which I've been really busy, as you know, in the last month, but it is on my list of things to try, and I do try and do things on myself or my husband before we try on patients, and then some trust people we've known for a number of years who will put up with a lot, and before I really will recommend it widely.
So one of my understandings with Marcons is that the potential for recurrence increases if your MSH is still low, and that once you can get the MSH to be more normalized, that then maybe the Marcons doesn't come back as readily. So are there things that after someone's done bag spray, done whatever they've done, and get a negative test, are there things they can do to minimize the chances of it coming back over time?
Those are really good questions, because I now ask patients to get tested every year, because I've seen so much recurrence. And I think one of the reasons we didn't see recurrence was Shoemaker originally cleared it and thought it was gone and was not retesting. And I started seeing it coming back or being harder. I started retesting and found, wow, a lot more people have this come back. And then we started doing dental, and that everyone who had dental did clear, but in several it has come back. And so one of the other things I didn't mention are household partners. In my practice, it seems about 60% of patients who are having recurrent Marcons, we culture the household partner, and the dog. I've rarely seen the dog positive. I have very often seen husband or older children positive. So testing the whole household is useful because everybody is spreading it. I think MRSA lives at least a week on hospital surfaces, and it's going to be spread just by, food, tables, bathrooms, share, anything, There's some article that says, someone who moves into a household knew that the inhabitants will be sharing their microbiome within 2 weeks or so, at least as measured on the feet. So people get very grossed out, but it's like, hey, this is the reality. Our bacteria outnumber our human DNA greatly, and we share them all the time.
And couldn't survive without them too, which I think people are surprised to hear, right? It's not always a battle against killing every bug and becoming a sterile being.
Right. So household partners are a big one. What is interesting, though, is that when people are healthy, they do a round of bag and they clear. They can show up with like 6 or 7 resistant for whatever reason. One round of bag, we retest and it's gone. And the ill person is still clearing too. So it's one of those things. It's like there is something different in people that are ill that makes it much harder for their immune system to effectively clear this colonization of their nasopharynx. And I've been fascinated by that.
It sounds like from your comment about people noticing some brain fog and other things kind of lifting as they deal with MARCoNS, that the answer is probably yes. But would you say that clearing MARCoNS is a requirement or important clinically in order for someone to recover from CIRS?
It seems that way.
Okay.
And I think, honestly, better research would help us answer some of these questions. Better research by prospectively following people in a controlled manner as to who gets better faster and who doesn't. MARCoNS does seem to play in it, but I would like to, see more research. And my own research is certainly the observations. Wow, if you're already healthy, it is much easier to get rid of this than when you're sick. And there are people who we just don't seem to be able, to be honest, to fully get rid of it. It'll clear and it'll come back. It seems to be, and I don't think I can ever recommend that we just totally try and eradicate it from every place we can think of. Tonsils, maybe.
Well, and I had talked to someone recently who they had a previous ear piercing that they occasionally got some fluid out of, and they sent in a swab of the fluid from the ear piercing, and it also was MARCoNS positive, which I thought was
amazing.
Yeah.
That's amazing. MRSA can grow in the vagina. We know that. I haven't seen positive MARCoNS cultures though either, and I don't know what it means. Again, we're reaching the limits of we can't eradicate everything. How do we make this better for people? And I think that's growing back the more natural biome may be the answer, the way it is for everything else in the body.
Yeah, that makes a lot of sense. Let's talk a little bit about VIP. So would you say that the goal of CIRS treatment in your patient population is to eventually introduce them to VIP? How significant is that in moving them forward? And then what's the split between patients that tolerate it and those that have to stop because they either didn't tolerate it or their lipase went up or some other complicating factor?
Yes. The goals of Dr. Shoemaker's protocols are to move sequentially through steps where VIP is the last step. In reality, there are many detours on that path, and I think a decision tree is sometimes a better word than protocol. If this, then this. If this, then this is better. But the actual end stage is VIP. It does seem to have helped a lot of people, both with energy because it relaxes smooth muscle and with brain issues. I certainly have had people feel their depression and anxiety lifted and stay lifted with it. The brain fog and the cognitive issues the brain fog may clear quickly. The cognitive issues may take a little bit longer, but it can be quite evident to people that their thinking has become more clear in many ways. And there are many ways in which thinking is impaired with inflammation in the brain. So,
and do most of your patients seem to be able to tolerate VIP by the time you get to that step?
Many do, not everybody. And I'm usually aware of which people I'm going to start on a lower dosage because they've reacted to everything else. They're people who are more sensitive, and there are people that I will be starting on lower dosages and won't be surprised to hear that they initially feel worse on lower dosages. But if you go slowly at lower dosages, every one of them has been able to get up to a normal dosage and benefit.
Is there some connection between glycine and helping the body make VIP? I had read somewhere that maybe you were exploring glycine and VIP.
I'm not. I certainly have read it too.
Okay.
And I think the problem with that answer is that VIP is being given at non-physiological dosage. So glycine may help the body make more VIP, but in truth, you can have normal VIP, or even with one patient who I finally gave the go-ahead to go ahead and treat, even though his VIP was very elevated, that the VIP you're inhaling is at a larger than physiological dosage. So I don't think you can get the same effects by taking glycine.
Okay, now that's helpful.
I should also, mast cells can secrete VIP. They react to VIP, they can make VIP. And I think that's why, because we could not find anything else in this one patient with very high VIP. I think that may be the answer. And that's someone who going up slowly has really benefited from pain and problems with headaches and brain fog.
So if you're suggesting that mast cells make VIP, are you saying that when someone has a mast cell activation syndrome, they potentially are producing more VIP in that state? Or did I misunderstand?
Possibly. I mean, mast cells secrete so many things that they make MSH. I have a few very high MSH patients, and I know I'm not ignoring your MSH question. I can think of about 5 patients whose MSHs are 50 or above, and they do better, all except one. They all seem to have mast cell issues too. And because I keep wondering, why are these people, making above, doses above 35, which you rarely see. And I think it might be their mast cells, especially. I don't know. You just look at all.
And it's so interesting because if in that case, all of the focus that people seem to have now on addressing the mast cell activation and reducing histamine and all of those things, is it possible that then we're actually doing the wrong thing from a perspective of VIP and MSH?
No, sometimes I joke with some of the other doctors that I hang with here is, maybe mast cells are really running the show for CIRS. They make MMP9, they make TGF-beta. They seem to react to, when you activate the innate immune system, mast cells clearly react and destabilize. And every time you find out that mast cells make something, it's something you might be measuring in CIRS. So it does seem to me, and that's where increasingly more and more of my patients, I work with mast cell issues and trying to stabilize them, because it's stabilizing mast cells that often produces even more improvement than VIP in some patients.
If you had to speculate on the underlying trigger for your patient's mast cell activation, because I know that's a hotly debated topic with lots of potential answers, do you think there are 1 or 2 key triggers?
Mold is clearly one of the major triggers. And I think even the doctors, Afrin and Theoharidaris, will say the same thing, that mold, they may not have written about it, but they certainly have seen it in a number of bad cases. In every patient I have, mold is an issue that set it off and is making it so hard to push it back into a place where it's doing what's appropriate. The reason I think that I see so much of it is histamine is a major player in the brain. So people talk about the neurotransmitters of the serotonin and dopamine system and catecholamines. Histamine is maybe more important in psychiatric illnesses than any of them. It certainly is a major contributor to that neuro-inflammation, the microglial activation we talked about earlier. It is linked, and there have been alternative psychiatrists talking about it for a long time, and they've been routinely made fun of and derided, pointing out that the histamine issues in the brain are very significant.
And it's interesting because you commented earlier that you kind of assume that many or most of your patients have parasite issues as well. And I've also read that parasites can be another trigger for mast cell activation. Right. So it's all this complex web.
It's an important thing to understand, though. And about 40% of the people I see, when I did it once with looking at it, have hypermobility or Ehlers-Danlos type 3 that's formally diagnosed. And genetically, there seems to be links between Ehlers-Danlos, hypermobility, POTS, and mast cell. And once I begin to see that or see one of them and look for the others, I've found that treating mast cell is running the show, whatever has set it off on the triggers. And in some ways, it's easier and certainly less expensive to treat at times, to try antihistamines, to try supplements, to stabilize mast cells, to make it easier to tolerate even cholestyramine or BAG, and eventually VIP. So you asked, those are the people that are usually more sensitive, react to everything. And the other reason it's important to distinguish mast cell, and there are a couple of ways you can distinguish. Angioedema is not a CIRS symptom, which is the swelling of the limbs or swelling of the throat. And the pruritus and hives is also not a CIRS symptom that anyone knows of. When those are present, you're probably looking at some mast cell problems. And there are more systems that can be involved. It's hard to tell, is the GI diarrhea mold or mast cell or both? Probably both for a lot of people. And so, but the skin symptoms and the swelling can be giveaways, is that when you recognize and treat that, people stop, quote, reacting and getting mold hits to everything. Because I do have a certain population that is made very miserable by the fact that everywhere they go and everything they do, they feel they're getting mold hits and they're reacting. Their brain gets foggy. They will not think as well. Their skin will, get red. They'll start to ache. And it's not all mold. And that's what I have to keep telling people, is this is not all mold. You can live a more normal life if you'll take some antihistamines here too and work with mast cell issues. And that has been true for everybody, that to focus only on the mold as causing all the reactions and to hope that binders and avoidance is going to cure everything, it makes people very miserable and doesn't work.
Yeah, absolutely. Yeah, the mast cell thing is becoming such an interesting topic and an important one. And I've seen many people that their life literally changed. I mean, the number of foods they could eat was down to 5, and they started supporting mast cell, and they gained healthy 20 pounds, and now they're much more stable and strong. So I think it can make a really big difference. I'm curious, I know with VIP, one of the potential outcomes is an increase in MSH in some people. And so I'm wondering, if MSH becomes available in the US, and I think there is a pharmaceutical drug potentially coming on the market more not necessarily for CIRS, but one that would provide MSH. Do you think there's a place for MSH in the treatment of CIRS, or is that not really even a tool that we think would be useful in the toolbox?
We all know the biotoxin pathway, and MSH is pretty much the primary component, but you have to realize that's all theoretical. It seems like it should work, but there's not actually the kind of research behind it that we could say, yeah, we had 20 people on MSH and 20 people off, and this happened or that happened. So it still is theoretical.
Okay.
And people will really focus on, if I had MSH, I'd be better. And I'll go, I'm not sure,
Yeah.
So I try and get people to realize, hey, there may be other pathways and other things out there, even if we don't get MSH up. 2 is the drugs that are coming is, we have colleagues in Australia, and I have patients in Australia. The drug is available that you're talking about in Australia, and nobody seems to have had miracles with it.
Yeah.
In Arizona, something similar has been made for a number of years, actually, as a tanning, the indoor tan glow, and nobody who's tried it and everybody finds it and tries it because you can get it, has had any significant or lasting success with it. I would like to see the natural hormone made available again, but the FDA took it off the market. It was used to treat female troubles interestingly enough. If that came back, that would be replacing that hormone naturally would be really interesting.
Very good. Thank you. So in your patients where Lyme and co-infections potentially play a role, how do you approach treatment of the Lyme and co-infections, and how often do you find that when Lyme is present in CIRS that they also have an underlying mold issue? It sounds like that's fairly universal.
No, there must be Lyme patients who don't have mold. I don't get to see too many of them.
Okay.
There are simpler patients, people who just have mold. They were perfectly healthy. They got mold. They recognized it. They got out of it, and they got well. And for Lyme, I think that exists too. That people have just Lyme and get better. But the people who are chronic, who are sick and really can't get the help locally, do tend to have both. And so I see two things. I see one, people, and unfortunately, mostly from California, who've been treated for a long time for Lyme with antibiotics, who had very little, if any, improvement, who finally heard about mold and realized, my God, my kitchen, has black mold and the landlord never took care of it. And I get to see a lot of those, and I wish, and I think it's happening more, that someone had figured this out faster, because the person has now done a lot of antibiotics. And you're never really sure, did they have Lyme to begin with? Because the test, those are cases, and I've seen a number of cases in which even the IGeneX was maybe suggestive, maybe not, maybe the eye spot was indeterminate. The tests were never really that clear, and yet they got a lot of treatment because they had symptoms, and nobody knew that mold and Lyme, the symptoms are pretty much the same. You can't really distinguish them. So I see too many of those people, and I hope that that's something that's becoming less and less as people catch on to mold now and realize they need to get out of it.
So when Lyme is an issue, then do you treat with herbs, or how do you approach the underlying infections if you
I try and
determine
get a diagnosis.
Okay.
So I have high index of suspicion. People have had tick bites but said nothing happened. It's like, okay, you were lucky enough to get the tick that didn't have anything. And you do hear cases of people say, oh, my doctor said I didn't have a bullseye and I was fine. Like, okay, I don't think so. Then there are the people who don't have any memory of the bullseye but were around ticks growing up or have been around ticks, and they're suspicious. I'll do a LabCorp Lyme test all the time. If they have more than 41 positive, if they have like 2 bands positive, especially if they have an IgM and 2 IgGs positive, I'll say, every time I've tested this with further testing, we show that Lyme is present. So I think this is pretty suspicious. And you'll ask me what test I use now. I use DNA connections the most. I just feel that for the money, you get the best and the most answers for people that, and I've debated with other doctors who say, wow, they seems like so many. It's, well, if it's the DNA is there, it's there. And I find it much better than maybe it's positive, maybe it's indeterminate. And I'll urge people to get that so we know what we're looking at.
So I know that we need to probably wrap up here fairly shortly, so I'm just going to touch on a few more questions. I'm going to skip over a few that I was potentially going to ask because I think we've covered so many more important topics. But one of the questions that comes up quite often is the Neuro Quant and how common it is to see a Neuro Quant that is suggestive of Lyme. And I think one of the things people don't necessarily understand is that my understanding is the criteria for Lyme is really based on acute Lyme.
Yes.
And so if you've had Lyme for any period of time, we wouldn't necessarily expect to see the Neuro Quant show that pattern. Is that correct?
That's exactly right. I have actually seen a few Neuro Quants that did have the thalamuses big enough to qualify. But yes, the research was done on people who had a known tick bite, a bullseye, a positive Quest Western blot or Stony Brook Western blot, which was considered pretty definitive they had Lyme. And they were the ones who showed the enlarged thalami, which is really interesting to me because mast cells, actually one of the biggest concentrations in the brain is in the thalamus. So I just find that that's interesting that that's it. So I'll see thalamuses that are close to that big and I'll say this could possibly be, an acute infection. And I think we should test here for Lyme. So it can sometimes be useful, but having a, quote, negative for Lyme test does not mean you don't have chronic Lyme or co-infections. And we have no way of knowing really what does Bartonella look like, what does Babesia look like. The Bartonella patients I've had who are confirmed tend to show the typical swelling, certainly in the frontal parenchyma and cortical gray, extreme swelling.
You've mentioned toxin binders a few times. I think people will be familiar with cholestyramine and Welchol. Are there any other types of binders that your patients find helpful beyond those two?
Clay and charcoal. I've used them for years. I've seen people get better. They're not my first choice simply because they're not the strongest, but they are my first choice in patients who I know that their constipation, gastroparesis issues are so strong that I'm only going to make things worse with stronger binders. Lots of other binders have been suggested, and I don't have really good data to support their use. Rice bran is one that's recently come to my attention. Somebody who I respect has said it does block enterohepatic circulation, which is the key. You have to do, if you're doing charcoal or clay or whatever else you've decided might be working, if you're not doing it at least 2 or 3 times a day, the toxins are still being allowed to be reabsorbed back in. And if that's happening, there's no point in really doing it at all. So, rice bran is good, evidently, for pulling out heavy metals, and it is a fiber which can help the gut too. So I've been recently recommending that more as a detoxification.
That's cool.
That's
awesome.
Just something I learned, and I'm pretty interested in that.
Yeah, awesome. I learned something new as well. So I know Great Plains recently introduced the Mycotox, which is their urinary mycotoxin panel. Real-Time Labs has theirs as well. I know there's been debate about the usefulness of looking in the urine for mycotoxins. What is your perspective on whether those are potentially helpful or not?
They're using a more specific test. They're using mass spectrometry, which is more accurate than the antibody testing. And if that's a constant theme you're hearing, is antibody testing is inexact, whether it's for Lyme viruses or the real-time labs. So I am definitely interested and watching, and one doctor I know has sent off split samples that are going to real-time and going to Great Plains to see what he sees. So we're always looking for better testing, more economical testing, something insurance might pay for, or something like DNA connections. If it seems accurate, it's worth the money to do an accurate test that we don't debate positive results.
Another area that I think there is some debate as well is if you are in a water damaged building where there's things like aspergillus and penicillium and other fungal organisms, is there the possibility that as we inhale these, that they also colonize in the sinuses or the gut? And I know in Dr. Shoemaker's work, that's generally not something that is considered as part of the Shoemaker biotoxin pathway, but do you think that there is potential for fungal or mold colonization in the sinuses?
I think I'd like to see better data there. And again, it goes back to the law of unintended consequences. So we know the bacteria do colonize, yet treatment, is it creating more harm? That's a question that you have to reasonably ask. So if you're going to treat now with antifungals too, antifungals create harm. And again, they keep growing out bugs that are bigger and smarter than the drugs that we're trying to use them. So I'm not looking to really add more things to my repertoire where I might be hurting somebody. If somebody showed me good evidence that, we've taken scrapings, are absolutely colonized, or here's a series of 50 controls, age-matched and sex-matched with 50 people prospectively who did antifungals orally and intranasally, I'd be impressed. But again, I think as I get older, I've seen a lot of patients. I've seen all the bad things that happen from things people, yesterday someone calling hysterically, she was given IV chelation for her heavy metal load. I've seen this one too many times, is when you are inflamed with inflammation, you don't want IVs being pushed in you to detoxify heavy metals where there can be some real damage, or even the ones done to, detoxify can just make people worse when they're really inflamed. So I get to see, because I've seen a lot of people, what bad things can happen, and I get more cautious and want people to get better in conservative ways that can really get them well and sustain them. And I don't hear a year later you did this and now I have cancer or something like that.
Well, and it's clearly working, because I've talked to many of your patients that have done tremendously, tremendously well and have their lives back. And so I think you're doing tremendous work, and your toolbox certainly appears to be quite adequate. As we wrap up, I know that Dr. Keith Bernston recently shared the news about the IC organization that's being put together, and I was wondering if you have any comments about that. I know it's launched on Facebook, and I believe there's either a website coming or maybe already in place. Maybe you can tell us a little bit more about IC and what the goals of that organization will be.
Yes, so IC is very exciting for us because it is a academic professional society that is dedicated to the exploration, research, and treatment of environmentally acquired illness, which is everything we've covered. Is our environment is toxic, the air, the water, the soil. Mold has become an increasing issue from probably damage to the environment, as well as things we've put in paints to, again, drive the production of more toxic molds, as well as poorer drywall, etc. And Lyme and all the co-infections and all the things that bite us and sting us, what they've been contributing to it is we're very excited to be able to work with a more full toolbox. To all of us who are working on this project are very interested in helping people in the sense of we have an increasing growth, and we see to us an epidemic of patients who get something treated. They get some sort of environmental mold or Lyme, or maybe it's heavy metals, and they get treated and they get so far. But what is the key? How do you turn them back on to health? And I'm sure that's something you're interested in. You've been working for many, many years, and we just see an increasing number of patients who are sick, and other doctors are still like, well, chronic fatigue, I guess it's more than depression. We're going, how do you turn this stuff back on? What is the key? Where is it? Is it the mitochondria? Is it the danger signal? Anyway, is it the hypoperfusion? So we're excited to be looking for how many ways can we help people, and we are very interested really in the respectful and compassionate treatment of patients with poorly understood illnesses, and that group is just increasing exponentially. And as far as we know, and we really will state this, as far as we know, a single protocol by anybody is inadequate to address this complexity, and that you need to really understand systems biology and have a functional medicine approach in order to approach this population. And that is the society that we have formed. We've had our first board meeting last Friday, which was successful. So we have a board, we have mailing lists up, or we have a website just about to be unveiled. We do have a Facebook page. We've made contact with many people who are very interested in working and learning and promoting the research and teaching. I would like other people to know the things I know, and Dr. Bernstein, Dr. Rappaport, Dr. Neil Nathan, Jill Carnahan, all these people you've interviewed, I'd like other doctors to know, how do you handle this patient who is complex, who has a chronic illness, that now they finally found a doctor who believes them, is what's the decision tree? How do you do this? And I think decision tree is a much better word than protocol, because it is not fixed, and how you approach it really has to take into account the patient, and it includes emotional toxicity. It is not just the environment. The emotional toxicity has been a part of people's upbringing and environment, and that contributes too. So we haven't even gotten into psychology, but certainly that is part of my toolbox and has to be part of anybody's, is changing outlooks and changing belief systems. And people who've had emotionally toxic childhoods have a harder time with whatever the illness is. That research is really good. Unfortunately, how to fix it is not as good, but you have to address those issues. And we all believe you have to give people hope. if you don't give them hope, you might as well give them a loaded gun.
Sadly, yes, I would agree. So I'm excited to see what comes from the IC organization. I will put the link to the Facebook page in the show notes for people that are listening so that they can find it. I know we'll be hearing a lot more about that over the next months and years. What do you do, as a last question, what are some of the key things that you do on a daily basis in support of your own health? How do you keep yourself going?
Okay, first of all, it changes because I am always interested in exploring what I just read about, and I am curious and will try a lot of things. So this might be what I'm doing now, and if you talk to me 6 months, I might be trying other things. But the basic things is I do enjoy creativity, and I think creativity is important if you want your brain to work fully. So I've always enjoyed music. I was thinking one thing that probably is not might not be known is that I played the cello for many years, and I actually played behind Yo-Yo Ma in college, way behind, but Yo-Yo Ma was a prodigy then. So I love music. No. And I also love photography and art, and technology has developed to the point where I can do a lot of digital art, and that's currently what I do. My husband, as you know, has been a photographer for many years before he studied nutrition, and we're able to do the wildlife. So we do a lot of that. And for health, I walk. This is a beautiful place to live, the desert, and swim and yoga. And I've taken up Qigong again, which I had learned, but some patients had said, wow, it's really helping. I thought, oh yeah, I used to do Qigong. I wonder if I started that again, if I'd have something to share with others. And Tai Chi, which I think is helpful for balance. And I just enjoy too, something that's not mentioned is all the supplements we could take, which we didn't have time to get into, but I think supplements and diet have an incredibly important place in anybody who's going to get better. Is I just really enjoy the desert, the quiet, that there's something incredibly wonderful about being able to sit in silence and think. And that's something I just thought I'd mention, is that right now, that's one of the things I'm enjoying the most, is being able to sit outdoors. It's gotten cool for us again, and to be able to sit outdoors and kind of listen to silence and just sort of watch the sun and change with the rocks and the wildlife. So that's what I'm currently doing. It's not the full list of every supplement or everything else that I've
no, that's beautiful. Yeah, fantastic. I was expecting you to turn around and play us out with the piano there.
No, I won't. But yes, and I encourage people to get better. You're asking everything to get better that you can buy in money and all these things, and doctors have to tell you, is to remember, go outdoors. What your mother would say, get off your butt and go outside and play, is walk outdoors, have some fresh air and look at something that's beautiful. No matter where you live, there is beauty somewhere. And I've done a fair amount of research, my own research into meditation, and I do have a meditative practice, which can change depending on how I feel. But you don't have to do a lot of technology, but just learning to kind of be silent and to appreciate something and see its beauty, even if you didn't think the rock or gravel was beautiful, is really important. So fresh air and sunlight and nature are part of getting well.
Absolutely. This has been
free.
Free. Absolutely. We like free. This has been super, super fun, really informative. We touched on several things I wasn't even expecting with the mast cell piece, which was fantastic and really insightful. I can tell that you truly, from your heart, really care about helping your patients and finding solutions and getting people to a better place. And I certainly appreciate that. I appreciate all the work that you're doing. And thank you so much for taking time to be here today to share with all of us. I appreciate it very much.
Okay. Thank you for letting me share with you and to talk, because it's in the talking that all of us learn, like, oh, you knew that? That's really interesting. I'm going to try that. And that's the piece that we hope to bring people together, and why I enjoy being able to do stuff like this.
Very good. Thank you so much, Dr. Ackerley. I appreciate it. All right.
Okay.
Be well. To learn more about today's guest, visit mypassion4health.com. That's mypassion, the number 4, health.com. mypassion4health.com. I appreciate your support of the Better Health Guy blogcasts series. If you'd like to follow me, you can find me on Facebook and Twitter as Better Health Guy. The show can be found on YouTube, iTunes, Google Play, and Stitcher. If you'd like to support the show, please visit betterhealthguy.com/donate. And if you'd like to be added to my newsletter, please visit betterhealthguy.com/newsletters. I'm looking forward to many more shows ahead and appreciate your interest.
Thanks for listening to this Better Health Guy blogcast with Scott, your Better Health Guy. To check out additional shows and learn more about Scott's personal journey to better health, please visit betterhealthguy.com.